Acute bacterial skin and skin infections can definitely be challenging to treat because, in part, actually, for a good thing, because we have lots of options out there to treat infections, and finding the right agent for the particular patient can be a little challenging. Weighing in what particular bacteria can cause the infection, as well as weighing in the patient's immunocompromised or non-immunocompromised state, comorbidities, leave open lots of options and choices, deciding whether to give someone oral antibiotics versus intravenous antibiotics, inpatient versus outpatient. There are a lot of decisions that need to be, factors that need to be weighed in when making such decisions into treating them. So areas of unmet need for ABSSSI, I think largely weigh in on pharmacoeconomically balancing what's available, getting patients on the therapy that is most efficient, not just in terms of restoring them back to their, life and back home and back to their jobs, taking care of their children and so on, minimizing stays in the hospital. Studying that and defining in a more black and white, more tangible fashion, I think is one of the largest unmet needs when trying to establish data for which clinicians to make decisions for treating ABSSSI. Yeah, so compliance in patients with ABSSSI can definitely be a big problem, largely because many of the patients are younger, they don't have a lot of medical problems, they don't take their health that seriously. They see the immediate need when they're very ill or when they have an immediate problem. And once their treatment is begun, then they forget about it, becomes less urgent, and they're off to their routines of their lives, not worrying about when antibiotics they have to take and how often. So clearly, with that kind of scenario, the less doses a patient requires per day, the better it's going to be. It's a lot easier for someone to remember to take a medication once a day as opposed to having to take something 4 times a day. For example, cephalexin, great drug on paper, covers staph, MSSA, and strep. Bad news is, how often is someone going to remember to take cephalexin 4 times a day? So the options of once daily dosing, and now we actually have drugs that can be even given once in an emergency room setting or an outpatient urgent care setting, where the patient can be given an IV dose that lasts a week and doesn't have to worry about taking any more doses. So unfortunately, the compliance factor is is balanced by the fact that some patients only need 2 or 3 days of antibiotics. They take their course, and many of them do fine. Unfortunately, there are some patients who do stop prematurely and they wind up having to come back to the hospital. So you're balancing I'm done, not taking more than I need to take, versus, okay, well, I stopped too early and then having to continue. Obviously, if you're worried about compliance, less doses per day and even eliminating the need to take any antibiotics with a parenteral one-time dose is one of the options we have available today. Yeah, duration of therapy, I think, it not only is sort of the black box, not only for ABSSSI, but also for all infections. How long to treat a patient is really almost a case-by-case basis. We have guidance 5 to 14 days or 7 to 14 days based on, historical paradigms. But at the end of the day, some patients are better with 3 days of treatment and they don't need any more. Some patients need, longer. One of the variables that determines duration of treatment is the patient's underlying immunosuppression and comorbidity state. Obviously, if you have a patient with more comorbidities, you're going to need to treat longer. If you have a patient who have a larger infection, larger burden of infection, you're also going to need to treat longer. So balancing the immunosuppression and infection burden of a particular patient, is a moving target patient to patient, and obviously very difficult to establish. With some clinical judgment and experience, a physician can decide, okay, you're a 5-day person versus a 10-day person, and hopefully make the right decisions, and hopefully the patient can comply with that recommendation to minimize, the needs, the relapses. Unfortunately, one of the problems you also have with this situation is with staph, is that patients who are colonized with staph frequently, you could treat them, they get through the acute period, but the mere colonization opens up an opportunity for another infection to happen. Not an issue of compliance and you didn't give them enough therapy, but the fact that they're colonized sets up an opportunity for a recurrent, and not necessarily a relapse infection, but a recurrent infection, a few weeks later, and we in practice see that all the time.